Good morning, everyone. The topic for today's seminar is duplication of gut, overview of its etiopathogenesis and its clinical management. Topics which we'll be covering in today's class will include introduction of gut duplication, its epidemiology, embryology, anatomy, clinical presentation, how to diagnose it, and the management. Duplication of gut is a rare congenital abnormalities that can occur from mouth to anus anywhere. It was first reported by Calder in 1733. Various names has been given to it. It is sometimes known as giant diverticular, anterogenous cyst, ileum or jejunum duplex, giant thoracic cyst, and simple duplication, reduplication, and sometimes it is called as unusual Meckel's diverticula. In 1937, Letts has given its name as duplication of the alimentary tract. Letts has given few characteristics which are defined for duplication cyst that includes the presence of a well-developed coat of the muscle. Second, it should have an epithelial lining which represents some part of the intestinal tract mucosa. And the third point being an intimate anatomical association with some portion of the GI tract. When these three characteristics are present, this is considered as duplication of alimentary canal. It is very rare. Most common presentation is in pediatric age group. However, it can occur in adult population also. It occurs in 1 in 4,500 of live births, can occur anywhere from oropharynx to the anus. Slight predominance is noted in male patients. It is of two types, cystic and tubular. Most common being the cystic occurs in 80% of the cases and 20% cases are of tubular. Cystic has non-communication with the adjacent bowel and tubular mostly is communicated with the adjacent bowel. Commonly, it is referred to as foregut, midgut, and hindgut duplication depending on their embryological origin of site. 10 to 20% cases can have multiple duplication cysts. High associated anomalies are seen, mostly common in foregut duplications, include spinal malformations, vertebral anomalies, intestinal malrotations, urinary tract abnormalities. Embryology, as a duplication of alimentary canal has various forms, no single embryological theory defines all the forms. So there are multiple theories which have impact on different locations and forms of the duplications. It includes split notochord theory, partial or abortive twinning, diverticular, canalization theory, and environmental defects. First includes the partial and abortive twinning. Basically, this is said that the gastrointestinal tract duplication occurs because of the incomplete twinning. That occurs because the duplication is basically we have seen cases which have multiple duplications involving the intestinal tract. That is, we have seen duplicated anus, duplicated genitourinary tract, and duplications of the head and mouth. So duplications of these tracts along with the duplication of the colon has been defined as the abortive twinning. However, this theory explains only the caudal duplication involving the colonic part. However, this theory does not explain the isolated cystic duplications which occurs throughout the intestinal tract. So this theory is partially covering the caudal duplication only. This is the barium enema of the patient who presented with the two anal opening. First, barium enema was performed from the anteriorly placed anal opening, which shows a colon, which is having loss of hostations and thinning. Barium enema was performed from the another opening, which was showed a dilated colon, which is a normal appearing colon. So this is a tubular kind of duplication seen in the colon. Another theory is a split notochord theory, which was presented by Bentley and Smith in 1960. According to this theory, normally an embryo contains two layers, ectoderm and endoderm, and mesoderm grows in between the two. A single opening appears in between the two, that is the notochord plate, and it grows dorsally and combines and pinched off from the endodermal lining. If somehow this endodermal adhesion remains patent and the notochord is unable to detach from the endodermal lining, it presents as a tract. This tract usually becomes patent, then it will form a fistula between the intestinal tract and the spinal canal. If it gets fibrous, then there will be a fibrous tract. And in most of the cases, this appears and forming a duplication tract only. This theory represents the duplication of the foregut duplication, that is in the respiratory system and in the thorax. Here we can have a spinal anomalies associated with the vertebral defect as well as the foregut duplication in the form of the bronchogenic cyst, neuroenteric cyst, or the esophageal cyst. However, this theory does not explain other cysts which occurs in the abdomen, which are the most common cysts. Another theory which was represented by Lewis includes the diverticular and canalization theory. In this, they have studied multiple human embryos in which they saw multiple diverticulars were present in the intestine on all the circumference of the bowel. And there are some diverticular also along with the duplication. So they thought these diverticulars are also responsible for the duplications. However, the failure of this theory was that duplication occurs only on the mesenteric side of the bowel. However, diverticulars were present in all the circumferentially in the bowel. Second, diverticulum and duplications were having same epithelial lining. However, in further slides, we will see that some duplications are there in which ectopic mucosal lining is present. So this theory fails to explain how the ectopic epithelial lining is present in the adjacent lining. Then Bremer postulated the theory that enteric duplication results from the error in the canalization. Normally, intestinal passes through a solid phase after which canalization occurs, and this canalization results into the formation of the lumen. However, if this canalization fails, it results into the formation of the duplication cyst. This theory has the failure that in the human intestine, solid phase occurs till up to the duodenum only. After that, there is no solid phase. So beyond the duodenum, if the duplication cysts are occurring, this theory fails to explain how it occurs. The last theory, which represents the vascular insufficiency theory, it was given by Malish and Co. According to this, trauma and hypoxia leads to the duplication and twinning in the caudal part. And this theory is in association with the intestinal atrasias. So the patients who are having intestinal atrasias will be having associated duplications. This theory explains only the part of the duplication which have associated intestinal atrasia. The patients who are not having intestinal atrasias will not be covered in this. Now we come to the pathology. Usually, duplication cysts are isolated lesions, can be of two types, cystic and tubular, and they are of variable size. And I have mentioned before that cystic is the most common type, being 82%, and 18% are of tubular size. It has muscular coat within the two layers, that is, inner layer will be the circular and outer layer will be the longitudinal, and it will have a lining epithelium, which will be in most of the cases similar to the associated portion of the alimentary tract. However, occasionally we see the heterotopic epithelium, most common being the gastric mucosa and second being followed by pancreatic tissue. If the gastric mucosa is present in the epithelial lining, it will have a risk of perforation, ulceration, and bleeding. Most of these cases present before 2 years of age, that is 80% of the cases, and 60% cases before, out of these 60% cases present before 6 months of age. This is the image of the cystic duplication, which is present in the ileal part of the intestine. The instrument is holding the cyst. This is the another part in which colonic tubular duplication is being seen. The two colon are divided. The contents of the duplications are usually mostly chyle and mucus, and it depends on the epithelial lining of the structure, its presence or absence, or a communication with the proximal part of the GIT, and the absence and necrosis of the duplication wall. Multiple duplications can occur in same patient. So if we are getting a patient who is having a thoracic duplication, we should investigate the patient for the abdominal duplications, as the abdominal duplications being the most common one. Anatomy. Most of these duplications are distributed in the abdominal cavity. 75% of cases occurs in abdominal, followed by intrathoracic, that is 20%, and the thoracoabdominal being 5%. Most common site of the occurrence is jejunal-ileum, that is 53% cases occur in ileum mesentery, followed by mediastinum, followed by colonic. Rest uncommon duplication cysts include gastric, duodenal, rectal, thoracoabdominal, and cervical duplication cyst. Clinical manifestations varies depending upon the size, location, presence or absence of gastric mucosa, its communication with the adjacent bowel, and the types of duplication, that is whether it is cystic or the tubular. Clinical manifestations which are defined based on the site of the site or the location of the duplication cyst include the foregut, midgut, and hindgut. Foregut duplications mostly arises from the esophageal part. Esophageal duplications can present with respiratory symptoms such as wheezing, pneumonia, and dysphagia. Less common symptoms may include failure to thrive, and sometimes respiratory distress can occur if the cyst size is large or it acutely enlarges due to the hemorrhage and infection that can further cause chest pain. Midgut duplication, which are most common arising from the ileum, can have symptoms like abdominal pain, vomiting, and abdominal mass. If it is having gastric mucosa as an ectopic tissue, they can have ulceration, bleeding, and perforation. Sometimes these cystic masses can have obstruction due to the formation of intussusception or the volvulus. Hindgut duplications, these are more complex kind of duplications which can have melena as a presenting finding or a second opening in the perineum. In the female patient, these opening can present in the perineum or in the vagina that can present as rectovaginal fistula also. Hindgut duplications are mostly associated with top caudal duplications, so they can have genitourinary abnormality, or sometimes they are large enough so that they can cause mass compression of the urinary tract or the rectum, presenting with urinary tract obstruction and several severe constipation. Sometimes they present in the presacral region and they mimic sacrococcygeal tumors. So, and to conclude, basically we have foregut duplication, midgut duplication, and the hindgut duplication. Foregut duplication can have esophageal duplications as well as gastric and duodenal duplications. Esophageal duplications can present with respiratory distress and obstruction, and all differential diagnosis includes all the intrathoracic mass, most common being the neuroendocrinal tumors of the posterior mediastinum. Gastric and duodenal duplications can present with hemorrhage and obstruction, and differential diagnosis may include pyloric stenosis and the gastroesophageal reflux. Duplication of the small intestine can again present with hemorrhage, obstruction, or intussusception, and differential diagnosis may include Meckel's diverticulum or the intussusception. Colonic and rectal duplications can present with constipation, obstruction, and also can differential diagnosis may include functional constipation or the Hirschsprung disease. Now we come to the diagnosis. Antenatal diagnosis, duplication cysts are the congenital anomalies that can be detected with the help of antenatal ultrasound. As these are available, the frequency of diagnosis of antenatally diagnosed duplication cysts are more. They are usually present in the chest and upper abdomen, identified on the ultrasound easily. If these mass lesions are large enough, they can cause mediastinal shift and can cause hydrocephalus in the fetus, and that requires further management in the form of thoracoamniotic shunting. Next, we come to the history and physical examination. History, that symptoms which are mentioned can be presented, followed by physical examination. Sometimes the chest mass is so large that it can cause the respiratory compromise. So on examination, we can have reduced breath sound or a chest fullness can be palpable. In abdominal duplication cyst, we can have a palpable bulky mass which can be tender and non-tender as per the presentation of the patient. In the laboratory workup, it is less useful, but however, if the patient is having gastric mucosa which is continuously bleeding and has caused chronic anemia, that can be seen in the blood investigations. And if sometimes there is duodenal duplication cyst which is causing pancreatitis, recurrent pancreatitis, in such patients we can have raised amylase and lipase. Main diagnosis is based upon the imaging, ultrasound being most commonly used. Intra-abdominal duplications are best identified by ultrasound. Typically, these cysts are anechoic until they have bleeding and perforation or ulcerations inside them. There is typical double wall sign which occurs due to the presence of the smooth muscles, a cystic rim of hyperechoic serosa, and an inner hyperechoic rim of the mucosa and submucosa with a sandwich hyperechoic muscular layer between the two hyperechoic layers. This is known as the double wall sign. As in this image, we can see that this is the hyperechoic mucosa and the surrounding smooth muscle layer is the hyperechoic lesion, which is giving the double wall sign. This is the duplication cyst seen at the gastric antrum. This is another picture of the colonic duplication in which the tubular type of cyst is mentioned with a double wall sign. Another imaging which is used as endoscopic ultrasound. These are most commonly used for the foregut duplication, typically the esophageal duplications, which are this helps in the differentiation of intramural or the extramural duplications, as well as they can tell us the solid and the cystic nature of the mass. Along with, if the diagnostic dilemma is present, we can go for the endoscopic ultrasound guided FNAC. Now we come to the cross-sectional imaging, that is the CT scan or the MRI. They can be used if the cyst is large enough, presenting in the respiratory and abdominal compartment, and the surrounding structures has to be seen for the surgical anatomy. In the CT scan, cystic masses can be seen with an enhancing rim due to the hyperechoic mucosa. This can be confused with an abscess. However, in the absence of septic features, the differential should be considered as a duplication cyst. Contrast studies are less helpful. However, they can tell us about the mass effect or the communication with the alimentary tract if they are present. Nuclear scintigraphy is helpful in cases such as patients who are presenting with abdominal pain and the melena along with the anemia. So the patients who are having Meckel's diverticulum can be confused with the duplication cyst. In such cases, the second differential has to be considered as a duplication cyst, and technetium 99 particulate scan has to be done so that it can tell us about the ectopic gastric mucosa which is present. To diagnose on the scintigraphy is difficult. However, intraoperative diagnosis can be made as the duplication cyst occurs on the mesenteric side of the bowel and the Meckel's diverticulum occurs on the antimesenteric side. This is the images of the same patient, single patient who presented with chest fullness and the difficult swallowing. On X-ray, we can see subtle rounded opacity, which projects over the spine. However, the rest of the X-ray findings are normal. For the same patient, CT scan was done, which show rounded attenuation at the subcaudinal mass, and it compresses the or arises from the esophagus. In the same patient, esophagogram was shown, and this shows the compression of the esophageal wall. It can be intramural or the extramural compressing the esophageal wall. And MRI was done for this patient, which has shown a fluid-filled level, which is centered on the esophagus. So all the modalities can be used depending upon the symptomatology of the patient. Now I will be coming to the management of duplication cyst. Thank you.
Good morning, everyone. We'll be now dealing with the management of alimentary tract duplication cysts. We have already seen the distribution of alimentary tract duplication cysts, most commonly in the ileum, followed by the esophagus. Coming to the cervical esophageal duplication cysts. In esophageal duplication, the distal esophageal duplication is most common, which is for about 60% of the patients, followed by cervical duplication, followed by mid-esophageal duplications. The patients present with respiratory distress, recurrent pneumonia, progressive dysphagia to solid and liquids, and chest discomfort. Majority are intramural, non-communicating cystic structures, usually located to the right side of the esophagus. Life-threatening respiratory distress requires urgent surgery. The diagnostic modality is CT scan and endoscopic ultrasonography, and the differential diagnosis would be of a cervical swelling could be lymphatic malformation, cyst of the airway or bronchial apparatus, or hieroglossal cyst. Coming to the surgical approach, these are usually excised by a supraclavicular cervical incision. Locally, usually they are located between the wall of the esophagus and the trachea. The cyst is dissected off the esophageal wall, and the residual mucosa is removed by stripping off or cauterizing. It is important to identify the phrenic and the vagus nerves, which are located, and the thoracic duct, which is in the same location, and prevent its injury. If the esophageal mucosa is entered, then primary repair is to be done with a pleural flap. And if on endoscopy we see a esophageal stricture, then a segmental resection might need to be done. It is important that all attempts should be made to reapproximate the muscularis over the mucosa, otherwise it would lead to diverticulum formation later. This is the clinical picture in the radiographical imaging of cervical esophageal duplication cyst. Coming to the thoracic esophageal duplication cysts. Thoracic or thoracoabdominal duplication cysts are about 20% of the total numbers. Mediastinal masses in infants are mostly neurogenic tumors, and enteric duplication cysts are a lesser common DD. These are usually present, majority of them are present in the posterior mediastinum and may protrude into either of the hemithorax or even both the hemithorax. The X-ray would show a air or a fluid-filled structure adjacent to the esophagus. Ultrasound and CT scan are other modalities, and technetium, as she's already mentioned, if heterotropic gastric mucosa is present, which is more common in the upper If foregut duplication cyst, then if heterotopic gastric mucosa is there, then we can identify that as well. Thoracic lesions on prenatal ultrasonography in utero therapy have only been made in cases of fetal distress with hydrops. Associated anomalies can be esophageal atresia and diaphragmatic hernia. Thoracic enteric duplication cysts, if they are having spinal anomalies, then multiple duplication is present in at least 1/3 of the cases. So these cases warrant that if a cystic mass is present in the chest with a vertebral anomaly, CT chest and abdomen should also be done to look for the duplication cyst. A barium swallow can be done to delineate the relationship of the duplication cyst to the esophagus and also to help us with the operative planning. And if we are suspecting a neuroenteric cyst, then an MRI spine needs to be done. This is the X-ray and the CT picture of a thoracic duplication cyst. And this is another one which is present in the lower 1/3 of the esophagus. It is a thoraco-abdominal one, which is also going into the abdomen, we can see. Coming to the basic principles of management of thoracic duplication cysts, primary excision should be done either thoracoscopically or by thoracotomy. Small cysts can be excised intact, whereas larger cysts might need decompression to facilitate dissection. Cysts present in the wall of the esophagus should be removed by opening the esophageal muscle, and extramucosal dissection of the cyst should be performed. After cyst removal, it is mandatory that we need to check that the esophageal lumen is not entered by instilling either fluid or air in the lumen, because missed esophageal leak will lead to mediastinitis and would cause severe morbidity for the patient. If at all the cyst cannot be entirely removed, at least the entire mucosal lining has to be stripped off so that the cyst cavity does not recur. Curettage and gauze packing of the cyst cavity to promote sclerosis are discouraged these days because they have a higher complication rate. Potential all ectopic gastric mucosa is supposed to be. This is a thoracoscopic picture or an imaging picture of esophageal duplication cyst, how it will appear. And this is another one in which this is the esophageal duplication cyst. The muscularis propria has been opened and this is the cyst is being enucleated. The cyst is removed and then the muscularis edges have to be reapproximated if possible. Coming to the neuroenteric cyst, these cysts present with a clinical triad of respiratory distress, chest X-ray, which is demonstrating a cervical or thoracic vertebral anomaly, and a posterior mediastinal mass. These patients are in high propensity to develop meningitis, or they might have acute or episodic or even chronic myelopathy. The treatment is simple resection of the cyst from the dura with draining of the cerebrospinal fluid into the pleural cavity with primary closure of the, or if possible, then primary closure of the dural defect. In neuroenteric cysts, it is important that the intraspinous portion of the cyst should be removed first. Otherwise, if it will not be removed, then most of the contents will go into the spinal canal and it will increase the chance of meningitis and postoperative swelling. Coming to bronchogenic cysts, these originate from the abnormal branching of the tracheobronchial anulage, creating closed spaces lined by either esophageal or by bronchial mucosa. These are usually lined by ciliated epithelium, and secreting mucosa is present inside it, which causes it to enlarge progressively. They rarely involve both the respiratory or digestive tracts and combines esophageal duplications with airway malformations. Most commonly, they are present around the carina and the mediastinum, and rarely they might also be present in the retroperitoneum. They may or may not communicate with the tracheobronchial tree, usually do not communicate. In the chest X-ray, paramediastinal round opacities can be found. CT and MRI will demonstrate the location and the size of the cyst, and endoscopy can be done if there is any external compression. They can be removed via thoracotomy or thoracoscopy. Coming to the thoracotomy approach, posterolateral thoracotomy is preferred. The lung is retracted anteriorly to expose the mass. And then the pleura around the cystic lesion is incised. And they usually lie either posterior or lateral to the bronchus or the trachea. And direct communication is extremely rare. This is a set of pictures which is showing the pleura is dissected off, is incised and is dissected off over the cyst. The cyst is removed and then it is closed. Coming to the thoraco-abdominal duplication cysts, these are usually located on the right side of the esophagus in the posterior mediastinum. They may either communicate with the stomach or even the small intestine through the diaphragm, or they may also communicate with the spinal canal. They may rarely present as with hemoptysis, as with the peptic ulceration with the gastric mucosa which is present in it may lead to ulceration and even erosion into the lung. For removal of thoraco-abdominal duplication cyst, it is preferred to start with a posterior lateral thoracotomy, or even a thoracoscopic approach can be preferred. The duplication cyst is dissected off first in the chest. If it is attached to the vertebra, then we'll have to dissect it from the bone. And if an intraspinal component is present, then a laminectomy has to be performed. After the duplication is freed of all of its attachments in the chest, it is traced distally to the diaphragm and it might be divided between ligatures. It is usually preferred to open the abdomen prior to the division of this part of chest, because it will be easier for us to identify the cyst in the abdomen as a continuation. We'll have to identify the continuation, close the diaphragmatic rent, and then we'll excise the abdominal part of the cyst. Often tubular lesion communicates with the small intestine, or it might also end blindly along the greater curvature of the stomach, which can be excised. Coming to the abdominal duplication cysts, gastric duplications, starting with gastric duplication cysts, these are associated with the stomach, mostly present on the greater curvature. The presentation has already been said. They may either present with palpable mass or can be antenatally detected, failure to thrive, vomiting, anemia, gastroesophageal reflux, abdominal pain, or even perforation. Ultrasonography is diagnostic. They rarely communicate with the pancreatic ductal system. The treatment of gastric duplication cyst is, if we can resect the cyst without violating the lumen of the stomach, then it is well and good. It has to be done. Otherwise, if it is densely adhered to a part of the stomach, then a segmental gastric resection might be warranted. Or if it is present all along the wall of the stomach, then what we can do is we can partially resect the cyst wall. The cyst wall can be resected and the mucosal stripping can be done. Gastrostomy or feeding jejunostomy may be beneficial if the gastric emptying is likely to be prolonged after resection. These are few of the gastric duplication cysts which are being excised. These are few of the surgical techniques. This one shows the partial segmental gastric resection. And this one shows a cyst which is present all along the greater curvature. So the wall of the cyst has been excised, the common wall has been spared, and the mucosa has been stripped off. In this one, partial excision of the cyst and mucosal stripping has been done. This is being done by using staplers. Coming to duodenal duplication cyst, the duodenal duplication first, third, and fourth part can be excised, but the second part duplication cyst should always have a preoperative MRCP. Investigations could be a CT scan or even an ERCP or an MRCP might be required for these. The treatment, although endoscopic or percutaneous drainage of duodenal duplication cyst is possible, however, still the preferred treatment is resection. We can either do a localized duodenal resection and reconstruction, or marsupialization of the cyst can be performed into the duodenum, or a small wall Roux-en-Y loop can be brought up and the cyst enterostomy can be done. I have a picture later. Or if the biliary or pancreatic ducts are involved, then partial excision can again be done with mucosal stripping. It is always important to use an intraoperative cholangiography to ensure that the biliary tree is intact and obstructed even after excising the cyst. These are two of the pictures which are showing excision of the duodenal cyst, in which first part duodenum has been, a partial duodenum has been excised and a jejunal loop has been anastomosed to the stomach. Gastrojejunostomy has been done. And this one is similar to the pancreatic pseudocyst, in which the duodenal cyst Roux-en-Y loop has been created and the cyst is draining into the jejunum. These are pictures of few of the duodenal duplication cysts being excised. Coming to small cystic intestinal duplications, cysts of the jejunum and ileum are excised preferably by resection and anastomosis. Duplications, if they are, these are usually the cystic duplications. These are performed, these are removed by resection and anastomosis of that particular segment because they share a common blood supply and also a wall. But if duplications are separate from the intestine and located in the mesentery, then it can be excised by separation of the two leaves of the mesentery, division of the vessels on one side of the mesentery, and the bowel can be, the duplicated bowel can be enucleated, and we can close the mesentery if the blood supply to the other bowel is preserved. Coming to the tubular intestinal duplications, short tubular can again be excised by resection and anastomosis. However, the problem comes with long tubular intestinal duplications. Few people allow for a close follow-up in asymptomatic cases in which there is no communication which is present between the cyst and the bowel. However, if a proximal communication is present, then it will become a blind ending loop because the intestinal contents will go into the duplication and it will be a blind loop. So it is said that we can also penetrate the distal common wall so that it will prevent the formation of a blind loop and it will form an alternate channel. If it is a very long tube, it is only done if it is a very long tubular duplication, and a resection and anastomosis of that amount of bowel would lead to short bowel syndrome. Only then it can be done. Also, submucosal excision can be done. Multiple enterotomies, as seen in this picture, can be made, and the mucosal lining is stripped off by multiple seromuscular incisions. This can also be performed. This is another method of a long treating of a long ileal duplication cyst, a tubular ileal duplication cyst, in which we can see that this is the duplication cyst, and here it is becoming one bowel in the distal ileum. So the distalmost part of the duplication cyst, along with the some part of the distal ileum, is excised, and a resection and anastomosis is done. And the duplicated bowel which is present, an enterotomy is made in this, and this is attached to the stomach. This is preferably done because most of the multiple times the intestinal ileal duplication cysts, they contain heterotropic gastric mucosa. So if we make an enterotomy and attach these two bowels, then what will happen is the acidic content will go into the distal ileum and will cause ulcerations. So it is preferred that this acidic content can drain into the stomach, which is actually made to deal with it. Yes, sir. Basically, sir, ये जो obstructed segment है, this segment we have excised, and this is the normal bowel ileum which we have anastomosed to the distal ileum. So this has been anastomosed. ये जो second blind ending loop है, this one, इसमें जिसमें heterotropic gastric mucosa है, इसमें we have made an enterotomy here, and this has been attached to the stomach. This is the enterotomy which is made. हाँ. Is attached to the stomach.
So the gut contents or the food
will not go into the stomach.
Only before it.
Earlier communication.
Earlier it was communicated.
Then why are you saying blind ending?
मतलब अभी blind ending हो जाएगा.
Is like how you decide which is normal and which is abnormal. So which one you give the continuity to the normal gut and distal ileum, and which part you attach to this one?
So जो tubular duplication है वो तो मतलब duodenum से पूरा normal bowel would be coming from the duodenum, jejunum, ileum, तो normal continuation में होगा.
How do you decide which is the duplicated one and
we can trace it back to the jejunum, the duodenum. We can see that we can trace it back mostly, and otherwise तो mesenteric side में होगा वो mostly the duplicated bowel.
These things are not very common, so it's a surgical challenge for a parents. People you can even connect both the units.
हाँ वो connection अगर proximal penetration is there, then we can do that also.
That's a better option. But it's always consider which one is which. When it's on the delivery side, but they say can, or you could have a dice study, or dice to be decided, it's a kind of which is going to be. So it's not very straightforward like that.
Unless it is a complete small intestinal duplication नहीं होगा, अगर ileal ही है तो we can trace it back, and jejunum loop जो communicate जो मतलब follow कर रहे हैं, we can follow that, and that will be the main loop, and the other one we can.
It's blind, then it's fine. There's no problem. Then you can say that okay, this one is the one which is not the part of the normal. But if it's not blind, then you know.
it's blind open media. Single for
सर ये वाला जो है नहीं मतलब ये वाला एक्चुअली दोनों के दोनों जुड़े हुए हैं इससे डिस्टल वाले से। सो जो हमारा हेट्रोटोपिक गैस्ट्रिक म्यूकोजा वाला जो है उसको हमने क्लोज करके वी हैव मेड एन एंट्रोटमी एंड वी हैव कनेक्टेड इट टू द स्टमक so that इसके acidic contents go into the stomach, but जो normal bowel की continuity है ये maintained है. This one is a RA which is done primarily. This is not communicating with this.
Proximally open,
नहीं, proximally तो open है sir. Proximally तो open होना चाहिए ना. Contents भी चाहिए. Closed.
Still communication there, and that is why you've done a resection. Otherwise, resection has to be done. Because there's still communication there, you want to stop that communication. That's why you do a resection with the outer inner bowel part. You isolate
Stomach communicators. So this is from Robin Smith operative surgery.
One hand is open, one hand is closed.
So it will not be there.
Because recent was-
हाँ sir. Recent.
Now you can be again very sure that there is heterotic acid glucose in that.
So usually मेकल स्कैन करके देख सकते हैं सर. मतलब सॉरी वो पर टेक्निक स्कैन करके देख सकते हैं. अदरवाइज अगर मतलब यूजुअली जैसे अल्सरेशन या फिर परफोरेशन हुआ है इस तरह का प्रेजेंटेशन है तो दैट विल बी डेमोंस्ट्रेटिंग के.
Because that's another thing that we are saying heterotic acid glucose है तो वो साइड हमने कर दिया. But we are not certain of the time that it heterotic acid. Any other method? Metal scan कर दिया. Any other method? Metal scan might not be can over tracks.
पर वो पोस्ट ऑफ आएगा बायोप्सी अगर करेंगे तो we can see मतलब वो हाँ.
I'm saying these are very interesting cases. This एक कोई केस इसमें देखा होगा रॉबर्ट स्मिथ में आ गया but it is not like life. So that's why I'm asking the reference from where it is. It's easy to call, but then they have to check this. It is not पूरे पूरे उसमें होगा. Yeah, that is multi-one कहाँ पर होगा
So method से अगर idea दें, you might find second area. That is हाँ, salvage procedure.
ये वाला जो प्रोसीजर है इसको देखना है कि ये एक्चुअली कितने केसेस हैं बिकॉज़ ये पहले तो नहीं था प्रोसीजर. पहले रैन प्रोसीजर था जिसमें कि आप म्यूकोसा को रिस्ट्रिक्ट कर देते हो. दूसरा प्रोसीजर जिसमें कि आप साइड टू साइड एनास्टोमोसिस कर देते हो. नाउ कनेक्टिंग इट विद द स्टोमक probably is the new thing which has come. The or maybe I am visited completely.
This thing which is gone out of
Yes, या फिर ऐसी बोल रहे हैं कि which is not yes.
सर इसको ये एक्चुअली मुझे बहुत इंटरेस्टिंग लगा था इसलिए मैंने ढूंढा ऑनलाइन बट इसका ऑनलाइन कुछ भी गैस्ट्रो डुप्लीकेशन नाम से देयर इज नो वो टेक्निक मतलब आई कुड नॉट फाइंड इट. दैट वाज द ओनली रेफरेंस जिसमें इसको था.
That is so fancy. They wanted to put in the textbook. That's how it is. They should have encountered the images rather than and drawn illustrations. देखना पड़ेगा क्योंकि एक्चुअली कितने केसेस हैं प्रैक्टिस हो रहा है नहीं हो रहा है और क्या है. तो ये जो डॉक्टर राहुल कह रहे हैं वो भी बात है कि आपने एक एंड ब्लाइंड है आपने एक जगह से कम्युनिकेट कर भी दिया
स्टमक का कंटेंट आ जाएगा.
बट इवन देन इसके अंदर स्टेप्स तो हो गए ना. इसके नॉलेज तो समझ कैसे रहेगा. हाँ वही इसका जो स्टेप्स हो गए ना आपने ये सोचा कि सीक्रेशंस वगैरह होंगे स्टमक से हो जाएंगे पर प्रैक्टिकली ये कितना यूजफुल होगा क्या ना मुश्किल है.
Coming to colonic and appendiceal duplications, total colonic duplications, they might also be present in the anti-mesenteric side rather they are the anti-mesenteric side rather than the mesenteric side. They usually communicate proximally with the bowel and distally they are blind ending. Cystic duplications may present with vomiting, volvulus, abdominal mass, urinary retention, abdominal pain, or even perforation. These are two pictures of total colonic duplication in which we can see that one of them is blind ending along the rectum and the other one is actually having a rectovaginal fistula, and this is the normally draining bowel. The types of tubular colonic duplications, type 1 can be in which there are two perineal ani. They have normal anal sphincters and are asymptomatic. Highest rate of genitourinary duplications are found in this type. Second type could be duplication in females with a fistula. That is, the fistula is either rectovaginal or a rectoperineal fistula. They usually present with constipation. Type 3 can be duplication in males with a fistula, which can be a recto-urinary fistula. This is a very rare subtype. Type 4 can be duplication without fistula with imperforate anus. That one of them is not having a fistula, it is imperforate. Or 2 anal dimples may be present, or 1 normal anus can be present with 1 dimple, which is not communicating. Type 5 can be a single perineal anus with a communicating duplication. The management of these are either ultrasound, CT scan, and barium enema can be instrumental in diagnosis of these conditions. And for treatment, the distal part of the duplicated colon may be connected to the normal colon with linear staplers, because it is a proximally duplicated colon, so it will be forming a blind pouch. So the idea is that we will communicate it distally as well, so the blind pouch will not be there. Or the distal part of the duplication may be resected if the duplicated colon connects to the urinary or urinary tract or vagina. Endorectal mucosectomy can be done, and the muscle cuff is then closed. The distal muscle cuff, it can be closed, and an end-to-side anastomosis can be done with the distal end of the duplication of the common normal colon. Coming to rectal duplications, it is more common in females than in males. The presentation is constipation, or there might be a separate anal opening, or there might be posterior rectal mass, or rectal bleeding, rectal prolapse, or even drainage of pus per anus. 20 to 40% have a fistula to the rectum or skin in posterior midline as a cone-shaped dimple. It might be present above or below the anal verge. I have a picture of. It might be present. Presentation and management is based on these 5 features: the size and the mass effect of that particular duplication, if there is a presence or absence of fistula, if there is any infection, presence of an ectopic gastric mucosa, or if in adults it might present with malignant degeneration. Diagnosis can be done by CT or MRI. This is a rectal duplication cyst, which has been which can be seen per rectally, and this is the CT image of the same. Treatment options: marsupialization as a treatment option only in the cases in which infection has occurred to allow for the resolution of sepsis before the complete resection of the duplication cyst. Transanal excision can be performed. The anus is dilated and retracted, causing the lesion to bulge forward. An incision is made on the rectal mucosa with stripping of the mucosal lining of the duplication cyst, keeping the dissection in the submucosal plane only, and the cyst can be excised from there. Or this is a previously used approach, transcoccygeal or Kraske approach. It was used for other tumors as well. Transverse incision is made posterior to the anus, and it may be necessary to remove the coccyx, and then from that approach, the duplication cyst can be removed from the posterior wall of the rectum. Mostly used is the posterior sagittal approach these days, with or without abdominal or perineal approach. This is the preferred approach, better for the axis, similar to the approach with Penna's approach for ARM. The rectum may be dissected from the muscles, and it might also be lifted off and bisected to reach the lesion. Usually these are posterior, these lie posterior to the rectum. So first we'll be reaching the duplication cyst, and after that we'll be reaching the rectum. This is a picture in which the duplication cyst has been excised from the wall of the rectum.
Yeah, that is fine.
नहीं sir, बाहर की।
ये कसम है। ये तो तुमने ट्रांस बताया है, कैसे करोगे? ट्रांस एनल प्रोसीजर को बताया।
So ये actually this is one of the case of transanal. इसमें इन्होंने क्या किया है कि abdominal and transanal दोनों approach use किया. So they pushed the tumor ऊपर से, it was a big tumor, so they pushed the tumor ऊपर से, and नीचे से वो anus को they have retracted, then they have incised the mucosa, and mucosa से basically strip वो mucosa को lift करके they have removed the cyst and then closed basically. So always जैसा जो endorectal dissection करके ऐसे. Coming to anal canal duplication, 3 types of anal canal duplication can be there if 2 separate perineal openings are present, which occur in association with colonic duplications, or colonic duplication with 1 normal and 1 imperforate anus terminating into a fistula, or to the genitourinary tract, or if both of them are imperforate ani terminating with or without a fistula to the genitourinary tract. This is a picture of a duplication. This is the normal anus, and here behind this here we can see there is a small opening. The main reason for the excision of the extra anus is cosmetic and prevention of malignancy in the redundant rectal pouch in these cases. There might be a thin septum between the ani and which might be resected, and both of these can be made into a single channel. If a very thin septum is present between the two two duplicated anal canals. Duplications that are associated with duplication of the genitalia usually are not fused. They are separate, and they usually have a separate blood supply. So one resection of one of the colon is usually possible from the other. If genitalia are single, then double colons are intimately fused. So it is preferable that the common wall between them should be excised and they can be anastomosed. The two coli can be anastomosed. Coming to the minimally invasive facial duplications are most amenable minimally invasive surgeries. We have to exclude intraspinal extension before going ahead with minimally invasive surgery in thoracic duplication cysts. Patient position is semi-prone at approximately 30 degrees. And abdominal to small duplications can also be done by a laparoscopic assisted approach, in which we can bring out the duplicated cyst along with the bowel from the umbilical port, and then we can go ahead with an resection and anastomosis. This is a small video of a thoracoscopic being removed. Mostly. Thank you.